Welcome to Neuro Frontiers, a series in which practical neurology partners with ReachMD to discuss topics at the forefront of clinical research and advancements that further clinicians' ability to diagnose and treat neurologic conditions. In this episode, Jack Reeves, PhD, researcher at the University of Buffalo Jacobs School of Medicine and Biomedical Sciences, discusses results of a study which demonstrated that high-efficacy disease-modifying therapies may help prevent the development of paramagnetic rim lesions and slow the progression of multiple sclerosis.
Hello and welcome to this episode of Neuro Frontiers. My name is Greg Jensen. I'm an editor at Practical Neurology. Dr. Reeves, thank you so much for joining us today. Could you please begin by telling us about your research focus?
My name is Jack Reeves. I recently defended my PhD in neuroscience at the University at Buffalo, and now I'm currently completing my medical degree at the University at Buffalo. My research focus is on chronic active brain lesions in multiple sclerosis. And a chronic active lesion is an ongoing microglial-mediated inflammation behind a closed blood-brain barrier. I'm studying this because despite great advances in disease-modifying therapies over the last couple decades that target the acute lesions, we still can't completely prevent MS progression in every patient. What I'm studying is the role of chronic active lesions in overtime disease progression. This includes clinical disability, as well as the health of the brain tissue itself, for instance, atrophy. I want to know what factors lead to chronic active lesion formation and resolution. And how can we target these to help them resolve faster or prevent them from occurring at all?
Thanks. I really appreciate you providing that overview of your research. And want to get into the study you presented at this year's ANA meeting, which focuses on the role of disease-modifying therapies in the development of paramagnetic rim lesions. Tell us about paramagnetic rim lesions. What are they and how do they develop?
A paramagnetic rim lesion is an imaging sign of a subset of chronic active lesions. Histologically, chronic active lesions are seen as a rim of microglia surrounding a demyelinated core, and these microglia have ingested a lot of iron. We can see this in iron-sensitive imaging techniques, such as quantitative susceptibility mapping, and actually then look at this in living people. Chronic active lesions can also occur in other ways, such as slowly expanding lesions. I personally like the paramagnetic rim lesions because we can detect them on a single scan using the iron-sensitive MRI. This could be readily incorporated into routine neurological workup for MS. We have found, and other groups have also found, that these paramagnetic rim lesions are associated with higher disability and also greater brain atrophy at the time they're detected, but also that they predict greater future brain atrophy. As to how did these develop, several studies have shown that these paramagnetic rim lesions or chronic active lesions develop from acute lesions. You have the acute gadolinium enhancing lesion, and then a subset of those go on to become paramagnetic rim lesions.
It's a really helpful overview. Thank you. The other part of your study is assessing the role of low, moderate, or high efficacy disease modifying therapies. Could you tell us a bit about the factors that physicians need to consider when deciding to treat with these low, moderate versus high efficacy DMTs?
That's a great question because there are so many options for DMTs these days. Everyone with relapsing remitting multiple sclerosis should be offered disease modifying therapy. And there's also evidence to show that patients in all stages of MS can benefit from DMTs. The question becomes, which DMT do you use? This can be boiled down into different categories of DMT efficacy. High efficacy DMTs are mostly the monoclonal antibodies, such as natalizumab, whereas the low or intermediate efficacy DMTs are oral medications, such as fingolimod or dimethyl fumarate, but also the older injectable DMTs, such as the interferons or glutathione acetate. There are two broad strategies when starting DMTs. The first is the induction or early intensive therapy. With this strategy, you start with high efficacy DMTs, for instance, monoclonal antibodies. And this is great because they are high efficacy and they tend to have a better effect in reducing the acute inflammation and relapses. But the downside of this is that these high efficacy DMTs also pretty severe side effects in some cases. For instance, people can develop severe infections such as progressive multifocal leukoencephalopathy. And then the second general strategy is what's called escalation therapy. In this strategy, we start with older injectable DMTs, such as beta interferons, and then scale that up or move to the high efficacy DMTs depending on if people worsen over time. The downside is these older injectable DMTs are not as efficacious as the high efficacy DMTs, but the benefit is that they are much safer and don't quite have the risk profile that the other ones do. A physician might choose their strategy based on a number of risk factors their patient has. For instance, these could be demographic risk factors. People who have late onset MS tend to worsen more quickly over time. Factors such as having a comorbid cardiovascular disease or demographic factors. We know that Black Americans tend to have a more severe course of MS than white Americans. These could also be clinical factors such as people with more frequent early relapses or radiological factors detected on their MRI. For instance, a high T2 lesion burden or a newly appearing T2 lesions on MRI. All of these come together and it becomes a shared decision between the physician and the patient as to which strategy to start and how to proceed with the treatment.
Thank you so much, Dr. Reeves and Greg. I'm Billy Irving. I'm a project editor at Practical Neurology. And Dr. Reeves, I wanted to ask whether you could please describe the key results of your study and what was the effect of low, moderate versus high efficacy DMTs on the development of paramagnetic rim lesions.
All right, so I'll start out with some background. Previous studies, as I mentioned, have shown that paramagnetic rim lesions predict greater future disability worsening. But the question is this specifically due to the paramagnetic rim lesions, or is this due to paramagnetic rim lesions acting as more of a biomarker for other forms of disease activity? For instance, more acute inflammation. And this is important once we start talking about drugs that might specifically act on these paramagnetic rim lesions. We've conducted two different studies to sort of look at this. The first study was presented at ANA, and we showed that a lack of new PRLs and resolution of existing PRLs is associated with decreased rates of confirmed disability progression and progression independent of relapse activity. The second form of disease progression I mentioned, the progression independent of relapse activity, is important because most of the previous DMTs were specifically designed to target relapse activity to prevent it from occurring. However, as we're learning in the MS field, a lot of the disease progression is actually occurring independent of any relapse activity, indicating that this chronic inflammation might be playing a bigger role than we previously thought in people getting worse. These results presented at ANA and actually have recently been published in the journal Neurology. So you can actually go and look that up online. The second study we conducted looked at the factors associated with new PRL appearance. And this was presented at the ACTRIMS conference and will be published soon. For this study, we found that people using any sort of DMT, whether it's high efficacy or low or medium efficacy, have lower rates of new PRL appearance than people not on any DMT. What this says is that it's important for everyone to be with MS to be on some sort of DMT in order to prevent these paramagnetic rim lesions. That sort of goes in line with current thinking about DMT use. However, we found that people taking high efficacy DMTs have numerically lower rates of PRL appearance than people taking low or intermediate efficacy DMTs. Now, this difference wasn't statistically significant, although this could have been due to the small number of people actually taking high efficacy DMTs in our cohort. This needs to be explored further, but it does provide some preliminary evidence or into future directions that we could look at into this difference between high efficacy and low or intermediate efficacy DMTs on PRLs.
You suggest that checking for PRLs is not part of the standard MS workup, but it should be. Why should physicians include checking for PRLs in the diagnostic workup of patients with MS?
The bigger reason is there's no consensus on which drugs to start for MS. As I mentioned, there's the multiple different strategies that the clinicians can employ, whether it's starting on high efficacy or lower intermediate efficacy DMTs. And at the end of the day, it is a shared decision-making process between the physician and the patient that balances the side effects of the drugs they're choosing with the efficacy and other things like convenience. What PRLs do is they offer a potential valuable clinical tool in aiding this decision-making process of DMT. For instance, as I mentioned, we know that PRLs are a significant risk factor for future disability progression. And they mediate some of the other risk factors we know for more severe MS progression. For instance, a part of the more severe progression seen in Black Americans is actually recently a study has been shown to be mediated by these PRLs. And also, as we've shown, a lack of new PRLs is associated with less clinical disability progression. What this all says is, when the clinician and the patient are looking at which DMT do I want to pick, with a lot of PRLs, they might say, well, you're at a very high risk of progressing over time. Therefore, the choice of DMT might be weighted more strongly into high efficacy DMT versus someone without any PRLs. Maybe that would lean more towards a lower intermediate efficacy DMT. But again, at the end of the day, this is a shared decision-making process, and PRLs might offer one additional tool for the clinician and the patient.
Dr. Reeves, what do you think are the future directions for research in this area?
The big thing, in my opinion, is that development of new disease-modifying therapies that specifically target these chronic active lesions. Now, there are a number of trials currently ongoing actually looking at this, and these paramagnetic rim lesions can actually be a valuable tool both in the drug development of these things and if any of these end up getting approved in sort of the clinical monitoring over time. Once you have someone on a drug, for instance, that might specifically target a chronic active lesion, you could follow a patient longitudinally and see how is this actually acting on this specific person. That's one area of future research. The second future direction I think that is important is improved intercenter consensus for PRL detection. Now, this is a relatively new area of research, and there recently were guidelines that were published sort of directing researchers on what defines a PRL and what doesn't. But there still needs to be a consensus or a coming together of the different groups to make sure we're all on the same page of exactly what is and isn't a PRL. And this will be important if PRLs are eventually to be adopted in the clinical setting, so that radiologists have a very standardized criteria for detecting these. And the last future direction I think is important is finding out what factors lead to PRL formation. And as I mentioned, our group has looked into this a little bit in terms of DMT use and other demographic, a little bit of genetic factors. But since these chronic active lesions and PRLs play such a potentially large role in disability progression, it is important to see what is actually causing these to form, what's causing them to eventually go away. These things tend to resolve after an average of 7 years. Why does that happen? And who does it happen to, and how can we prevent it? I think that's kind of the ultimate end goal is figuring out how can we prevent this from happening, and to do that we need to understand why it's happening.
Thank you so much, Dr. Reeves, for your time and your insightful comments into PRLs. We really appreciate your time, and thank you for joining us today.
Thanks to Dr. Reeves for sharing his knowledge with our listeners in this episode of Neuro Frontiers. And thanks to you, our listeners. Be sure to visit practicalneurology.com for more podcasts in the field of neurology.